Can I start my lecture?
In a moment, Doctor.
Okay,
Ellen, please open the session.
okay.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon and regards to our respectful attendees. My name is Ellen and I will be your host today. Before we
Recording in progress.
please allow me to acknowledge and greet some familiar faces in the audience. I would like to welcome and express my gratitude to our honorable guest, Dr. Sarwer Jamal Biplob from Bangga Bandhu Sheikh Mujib Medical University, Bangladesh, for taking the time out of his busy schedule. Next, I would also like to extend a warm welcome and appreciation to our respectable Head of Oral Medicine Department, Professor Irna Sufiawati, Head of Oral Medicine Study Program, Dr. Nana Nurnaini, Head of Unpad Dentistry International Office, Dr. Dewi Zakiawati, and all faculty directors. Lastly, I will also like to thank and welcome the students and all participants for joining us today. We are also delighted to inform you that this event is being broadcasted live on the Info FKG Unpad YouTube channel. Greetings as well to everyone joining us online. Ladies and gentlemen, as today's lecture is being conducted virtually, I would like to provide you with a few instructions for the smooth running of this event. Please ensure that your microphone is muted throughout the duration of the lecture. If possible, please adjust your camera settings and utilize our virtual background feature. Should you have any questions, you may raise your hand virtually to seek permission to speak, or alternatively, you may type your question in the chat box. Unless it pertains to questions related to the lecture, we kindly ask that you refrain from using the chat box. Thank you for your cooperation. Our agenda today will be a lecture by Dr. Sarwer Jamal Biplob entitled TMJ Disorders, Myth versus Evidence-Based Approach with Dr. Dewi Zakiawati as the moderator, followed by a discussion. Then there will be appreciation and documentation, followed by closing. Before we begin, let us all join in a prayer for the success of today's event. Let us respect each other's beliefs and pray accordingly. Let the prayer commence. The act of praying is sufficient. Ladies and gentlemen, before we start the lecture, we would like to take a documentation, and our documentation team will help us to take the documentation. We will do it on my count for the first slide first. 1, 2, 3. And for the second slide, 1, 2, 3. Thank you. Ladies and gentlemen, our main agenda will be moderated by Dr. Dewi Zakiawati. Everyone, please welcome Dr. Dewi Zakiawati.
Yeah, thank you, Ellen. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, distinguished professors, lecturers, residents, students, and oral medicine alumni. Welcome to the second session of our guest lecture series organized by the Oral Medicine Study Program in collaboration with the Unpad Dentistry International Office. Today, we are honored to welcome our guest speaker, Dr. Sarwer Jamal Biplob, an expert medical officer in oral and maxillofacial surgery from BSMMU, Bangladesh. Ladies and gentlemen, Dr. Biplob will present a lecture entitled TMD Disorders, Myth versus Evidence-Based Approach. As a reminder, the session will run for an hour, approximately 45 minutes for the lecture and 15 minutes for the Q&A. Without further delay, please join me in welcoming Dr. Biplob. Time is yours, Doctor.
Assalamualaikum. Thank you so much, ma'am. It's always a pleasure to be with you and your student. So I'm going to start. Please share my screen. Can you see my lecture screen?
Yes, doctor.
Okay, thank you. Thank you so much. So temporomandibular joint disorder is a kind of most confusing disorder I came across in last 10 years because lots of things are currently evolving and lots of things are updated so that we need to know what to do and when to do. Okay, without further delay, let me just start my lecture. So with the TM joint anatomy. If we want to focus the TM joint anatomy, it consists of condylar head along with articular disc and the glenoid fossa, that is temporal component. So this articular eminence. And truly the condylar head is attached with lateral pterygoid muscle and it pushes the disc towards the anterior direction with its ligaments. So for better understanding, I just repeat the video. See, these are typical temporomandibular joint with condylar head, articular disc, and glial fossa component, in which anteriorly there is articular eminence and posteriorly there is our extra auricular meatus, external auricular meatus. Okay. Okay. So today we will discuss the anatomy, physiology, pathophysiology, imaging, diagnosis, and management of the temporomandibular joint disorder. So from cadaveric anatomy. So this is a normal temporomandibular joint, okay? And this is a normal movement. So from this video, we can learn that condylar head and disc always lies in a synchrony, so that always on articular disc lies along the superior part of the condylar head and in between glenoid fossa and condylar head. So so back to the anatomy. So these are condylar head. So these are condylar head, and this is the joint component. So for with the discs, articular discs, we can divide our joint component in two parts: upper joint compartment and lower joint compartment. And the discs anteriorly attached with lateral pterygoid muscle, and posteriorly it is attached with biliminar zone or retrodiscal pad. And laterally it is attached with lateral ligament of the capsule or lateral ligament of the temporomandibular joint. Okay. So with this normal anatomy, we found that upper joint space, that is space in between articular discs and glenoid fossa, is around 1.2 ml, 1.2 ml space or 1.2 cc space, where it can accumulate around 1.2 cc of fluid, synovial fluid, and the lower joint compartment, that is in space in between articular disc and condylar head, it around 0.5 ml fluid. Okay, so very small joint and small space, and this fluid comes from the synovial membrane. Synovial membrane forms this kind of fluid which is called synovial fluid, which acts as a shock absorber, and it lubricates the joint and facilitates the smooth condylar head movement. Okay, so as discs, regarding to discs, normal position of the disc, it always tries to lies in between condylar head and mandibular fossa. But in normal population, we can find 30 to 40% displaced discs in normal population. So discs can be displaced anteriorly mostly or medially around 30 to 40% normal population. This is a very good data because most of the time we think that if the patient comes with the MRI report that shows us that disc is anteriorly displaced, so not like that he is suffering from disc displacement with reduction or without reduction scenario. Okay, so because normal population around 30 to 40% normal population can have displaced discs. So on that note, regarding to the movement of the condylar head, so regarding to the movement of the condylar head, just okay, so this is the movement of the condylar head. So initially condyle rotates, that is called rotational movement in the lower joint compartment. So initially there is rotational movement in the lower joint compartment, followed by transflexion sliding movement in the upper joint compartment. That's why TM joint is called gingival arthrodal joint, where at first there is rotational or hinge movement in the lower joint compartment and followed by translatory movement in the upper joint compartment. So initial rotational or hinge movement around 20 to 25 millimeter and followed by sorry, translatory or sliding movement around 10 to 15 millimeter, which accumulates normal TM joint movement, which is roughly around 40 to 45 millimeter. Okay, so initially rotational movement and followed by translatory movement. So if there is any kind of disharmony or dyssynchrony in between this kind of movement, we can find that limited joint movement, either it is limited rotational movement or limited translatory movement. So if there is limited translatory movement, we can call it hypotranslation. So patient may comes with around 20 to 25 millimeter, which is normal rotational joint, followed by no or minimum translatory movement. So ultimately, clinical feature can be revealed like that the patient has restricted mouth opening due to hypotranslation of the condylar rate, and hypotranslation occurs in the upper joint compartment. Okay, so always we need to focus the amount of the movement and type of the movement. Either it is rotational, either it is translatory. And again, from dynamic MRI, we can clearly appreciate the condylar head movement like this. So these are articular discs and these are condylar head. And during normal movement, this is the normal rotation. This is the normal movement of the condylar head. Initially, rotational movement and followed by translatory movement of the condylar head. Initially, lower joint compartment, which is around 20 to 25 millimeter, and followed by upper joint compartment, which is around 10 to 55 millimeter, and ultimately 40 to 45 millimeter normal mouth jaw movement. And again, from cadaveric anatomy, we can found the same. See, initially rotational and followed by translatory, and the same thing. See, okay. On that note, this is some kind of radiological TM joint anatomy. So this is the coronal section of the TM joint from CBCT scan. So this is lateral pole and this is medial pole, and this is the joint space in between condylar head and glenal fossa. And this space is dedicated for articular discs, and which further divides into two parts, either upper joint compartment and lower joint compartment. So upper joint compartment roughly around 1.2 ml, and lower joint compartment is roughly around 0.5 ml. Okay, and this is the MRI view of the temporomandibular joint. So this is lateral pole and this is medial pole, and this is we can clearly appreciate the discs from MRI view. And this is the sagittal scan. From sagittal scan of the CBCT, we can clearly appreciate the articular tubercle anteriorly and posteriorly external acoustic meatus, and this is the joint space. Okay, and this is the anteroposterior dimension of the condylar head, and normally condylar head locates in between the glenoid fossa, almost in the center position, and roughly it is around 3/4 of the total glenoid fossa space. So if total 3/4 of the total amount of the glenoid fossa space is around condylar head, and this is the discs in the MRI sagittal section. So these are discs, okay, which locates in between condylar head and glenoid fossa. So from this kind of anatomy, regarding to the lateral and medial pole is the weight bearing area, okay, or load bearing area. So if there is any sclerosis or regenerative process, we can find in the CBCT, it means there is an increased load bearing scenario along the medial pole. Okay, and again, if there is erosive changes in the medial pole, then again we can thought that this is some kind of resorptive changes or degenerative changes occurs due to the excessive load along the medial pole. Okay, so this is very much important to find out in the imaging section. And again, again, this normal space is very much important because this normal space is essential for foster normal mandibular or maxillary growth. Okay, and it provides us proper load distribution, and it provides us the repeatable condylar position like the synchrony in between articular discs and condylar head that we have already discussed earlier. Now, what is the normal position of the disc? The normal position of the disc is the posterior border of the disc. See, this is the posterior border of the disc. We all know disc has three parts: anterior border, anterior pole, posterior pole, and the medial pole. Medial pole is the thinnest part of the articular disc, and mostly this is avascular zone. Okay, and innervated zone. So no innervation in the along the medial pole, but in the anterior pole and medial pole, both are this polar thickest part, and there is no innervation along the anterior and medial pole also, but it is highly innervated along the retrodiscal pad, and it has its own blood supply from the superior superficial temporal artery, and it got its innervation from the auriculotemporal nerve, which is a branch of the mandibular nerve, which is a branch of the trigeminal nerve. So normally the posterior pole of the articular disc lines along the just like a vertical line along the vertical plane along the mid portion of the condylar head. So if we can imagine this is a mid portion of the condylar head from the sagittal section. So posterior border of the disc should be aligned like this. Should be aligned like this, the posterior border of the disc. Okay. So this is a normal position, and it can deviate up to 30 degree from its normal position. But if it is more than 30 degree from its normal position, then we can say that disc is not within its normal position. It can be displaced, and most of the time it is displaced along the anterior direction or anteromedial direction. We will discuss regarding this in later sections. And again regarding to the space, that is space in between articular eminence and external acoustic meters, it is around 8 millimeter, and 2/3 of this space is occupied by the normal condylar head, normal ideal shape condylar head. Okay, 2/3 or 4/3 of this space. Okay, so if the condylar head is resorptive, the what we are find in case of juvenile idiopathic osteoarthritis or juvenile idiopathic arthritis case, where we can find pencil shaped condylar head. So there will be increase glenoid fossa space, like normally it should be 2/3 of the socket space. Then we can find it is almost half of the less than half or almost 1/3 of the socket space or glenoid space due to resorptive scenario. Okay, and again from mediolateral direction it is roughly around 20 millimeter as mediolateral direction, and it can be decreased also in the resorptive scenario, either from the rheumatoid arthritis or osteoarthritis cases. And again from the vertical height, we can measure vertical height directly from the panoramic directly from the CBCT scan from the tip of the condylar head in the middle portion and from the angle of the mouth. So it is roughly around ramus length around 60 to 75 millimeter. If we can add ramus length plus the joint space length, then we can find the actual vertical dimension. So vertical dimension of the TM joint is the accumulation data of soft tissue, that is from the disc, and the hard tissue, that is from the ramus length. So this is the total vertical dimension. So if there is any kind of resorptive changes along the condylar head, so ultimately it results into the reduction of the ramus length and ultimately reduction into the vertical dimension. Okay, so what is TMD? Temporomandibular joint disorder or TMD, kind of umbrella term of musculoskeletal and neuromuscular conditions of the temporomandibular joint, what is associated with its normal anatomy and physiology. Okay, so TMD can be considered as one of the major cause of the pain of non-dental origin of the orofacial region. Okay, so There is a very recent paper from American Association of Oral and Maxillofacial Surgeon. They coined a new term which is called intra-articular pain and dysfunction, that is IPD, rather than internal derangement and anterior disc displacement, which we are normally used in our previous days. So IPD involves synovitis, capsular impingement, symptomatic disc displacement, or combination of these. So previously, if we can find any kind of disc displacement, either it is anteriorly, medially, or laterally, this is considered as a pathology. That is disc displacement either with reduction or without reduction. But with this position paper from 2024, from American Association of Oral Maxillary Surgeon, they want to conclude like this: if there is a disc displacement but there is no symptom, so this is not a pathology. So we should only consider if there is a symptomatic disc displacement with synovitis, capsular impingement, or combination of this as a intra-articular pain and dysfunction. Okay, so this is a new term, we should follow this. And these various kind of temporomandibular disorder ranging from joint pain, that is arthralgia or arthritis, joint disorders like disc disorder, disc displacement with reduction, disc displacement without reduction, or with intermittent locking, with displacement with reduction, with intermittent limited mouth opening, and hypermobility or hypomobility disorder. We can find joint disease also ranging from osteoarthritis, and systemic arthritis like rheumatoid arthritis, okay, seropositive or seronegative arthritis, this kind of stuff. And we can find fractures, aplasia, myalgia, this kind of scenario. We can clearly classify this kind of scenario in later sections. So what about the prevalence? So prevalence of the TM joint disorder from our literature, according to vision, that South African people are mostly suffering from this kind of TM joint disorder, and after that, the Asian people, we all are the people from the Asia, we are suffering around 33%. This is a huge number of patient load in this perspective. And again, regarding to the age, the mean age group is 16 to 35 years who are suffering from this kind of TM disorder. And regarding to the distribution of the TM disc patterns, we can see disc displacement scenario is the most common, that is 40%, and after that myofascial pain dysfunction syndrome, that is we are called MPDS, around 36%. See the and arthritis, either it can be osteoarthritis or rheumatoid arthritis or any kind of arthralgia scenario purely, which is around 13%. So mostly our patient are suffering from disc displacement scenario from global perspective data. So in our country, we are trying to establish our own data, but these are currently we are lacking of that. So from existing scenario, we can find that around 50% are rural and almost 50% are urban population are suffering from this kind of TM joint disorder. Okay, so now in our country, to deal with this kind of disease, these are the current heroes from my perspective, are muscle relaxant, that is tolterodine hydrochloride, painkillers ranging from NSAIDs, and antidepressive like amitriptyline, nortriptyline, and sedative like clonazepam, diazepam. Okay, and as some doctors also tried with occlusal splint, some are trying with physiotherapy, and some are trying with laser therapy, and some are trying with acupuncture. But we need to know what to do and when to do, because our patients are suffering from pain. So at first, we need to know, or we need to identify what is the cause of the pain, what is the pathophysiology of the pain. So regarding to the pathophysiology of the pain, we can find the cause may be bruxism. Okay, there is a form of chronic microtoma. Cause may be occlusal disharmony like class 2 malocclusion from deep bite, or class 3 malocclusion, or maybe any kind of direct trauma, either from for sports injury, okay, or from any kind of indirect trauma, or patient may be suffering from any kind of autoimmune or systemic disease ranging from rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, juvenile idiopathic arthritis, gout, this kind of thing. Okay, so we should we should try to clearly define the existing scenario ranging that I have stated here. So this is a bruxism scenario and this is the orthopedic scenario. Okay. Now, so cause of the pain, most of the time it is associated with mechanical loading, that is increased load of the temporomandibular joint component, which results into the hypoxia of the joint component, mostly the articular discs and synovial membrane, which results into the formation of the free radical. Hypoxia results into the free radical, and these free radical are responsible from the breakdown of the hyaluronic acid, usually which is a hyaluronic acid, which is a component of the synovial fluid and which is responsible for the lubrication joint. So, due to formation of the free radical, ultimately there is breakdown of the hyaluronic acid and which causes reduced lubrication of the joint and ultimately turns into the increased friction on the joint. As when we can get increased friction of the joint, it ultimately results into adhesion and fibrosis due to increased formation of the fibronectin and fibrosin cross-linking. So ultimately, in clinical scenario, we can find disc displacement with reduction, or in the later stage, we can find disc displacement without reduction. So main culprit is mechanical loading in the most of the time, and ultimately free radical formation, which results in the breakdown of the hyaluronic acid, which causes the decreased lubrication and ultimately formation of the adhesion and fibrosis within the joint capsule, which results into the disc displacement, either with disc displacement with reduction or without reduction. Okay, and now from the position paper stated from 2024, they state that IPD may be ranging from synovitis, that is inflammation of the synovial component, okay, fibrous addition or impingement that I have already discussed from the free radical perspective or mechanical loading perspective, and symptomatic disc displacement. So discs can be displaced anteriorly, medially, anteromedially, but there should be symptom, painful symptom. Without any kind of pain or without any kind of symptom, but a disc displacement should not be considered as a IPD. Or we can find the combination all of this, that is synovitis, fibrous adhesion, and symptomatic disc displacement. Okay. So they recommend as a 4 key pillars for patient care. Number 1, we should go through thorough history, screening, and physical examination. Number 2, appropriate diagnostic imaging. Number 3, make correct diagnosis. And number 4, start with least invasive evidence-based non-surgical treatment at first and followed by surgical treatment. So these are the 4 pillars for the care of the temporomandibular joint patient, that is IPD patients. So starting from the history, we should at first focus on the like this kind of historical component, like onset of the pain. When did pain start? Either in the morning or in the late evening. Okay, if the pain start in the morning just after waking from the bed, it mostly due to osteoarthritis. Okay, but if the pains results or increasing after the whole day, the late evening or the early evening, then we can think it is a arthrosis scenario, like due to mechanical loading. Okay, so is there any kind of triggering factor? Is there any kind of triggering factor? Like if there is any kind of triggering factor, like during mastication, during chewing, okay, the pain is aggravated, then we can consider that it is due to, as during mastication, we all know there is increased load in the joint component, either in the muscle component or in the distal component. Okay, so we can think that this is can be from the muscle or this can be from the joint. Okay, and then what is the location of the pain? So if the patient can identify the exact point of the pain, exact point of the source of the pain, then we can think either it is myalgia or arthralgia. Okay, and then what is the duration of the duration and the frequency of the pain? Either it is pain is constant or it is comes and go. Like if most of the time TM joint pain is kind of dull pain and is a constant pain. It can be aggravates with the use of the joint, like with the mastication of hard food or yawning or increased mouth opening. It can be increased, but most of the time it is a constant pain. If the patient complaining that they have the constant pain, that means this joint is not that much good. This is kind of degenerative changes. Okay, so this is a advanced joint disease. But if the patient complains that pain, kind of episodic pain, like for a very short duration, like 10 to 5 second, 5 to 10 second, or 1 to 3 seconds, and just like kind of electric shock like pain. Okay, so then we can reconsider that either it is neuralgic pain or TMD pain, because most of the time TMD pain does not shows any kind of electric shock like pain or short duration pain. Most of the time pain is continuous in nature and moderate to severe, not like paroxysmal pain, what we can find in the trigeminal neuralgia, glossopharyngeal neuralgia, or auriculotemporal nerve related neuralgic situation. Okay, and again quality of the pain. So I already discussed that is either it is dull aching or burning or throbbing pain. Most of the time throbbing pain is associated with neuralgic pain, but in case of TMG we can find a dull aching pain, the constant or episodic in nature. Okay, and intensity, most of the time it is ranging from 5 to 8, that is moderate to severe kind of pain. Okay, so we can rule out the alleviating factor, that is from the occlusal appliance, from the medication, from the physiotherapy, injection, and stuff. And we can make some kind of questionnaire for this. And regarding to the mandibular range of movement, that is we have already discussed that is normal mouth opening can be 35 to 50 millimeter or 40 to 50 millimeter. It varies from anthesity to anthesity. And the lateral joint movement should be lateral lateral joint movement around 5 to 10 millimeter in either direction, right lateral or left lateral, and pertussive movement around 8 to 12 millimeter. Okay, so we should check, is there any deflection or deviation? Okay, or what is the velocity of the range of movement? Either it is very slow or it is very fast. Okay, or if there is any kind of jerky movement during joint opening. Okay, or is there any kind of joint noise, either clicking, popping, or crepitus? Okay, so we can divide joint shifting into direction, that is joint deviation and deflection. Joint deviation means during starting of the joint or during starting of the mouth opening, it can deviate in the either side, either in the right side or in the left side. But in the full mouth opening, it can again back to its normal position. So initially deviates either in the right side and again back to the normal, or it can deviate either in the left side and again back to the normal. So in the deviation scenario, it always back to the normal, that is in the back to the midline. Okay, this is called deviation. But in case of deflection, from opening, from the initial opening to the final opening, jaw deviates either into the one side, either in the right side or in the left side. There is no comes back in the midline. Okay, so in the deviation, mouth mouth again comes back in the midline position, that is in the deviation scenario, and the deflection scenario is totally deflected from the midline, either deflected to the right side or deflected to the left side. So usually deflection is associated with unilateral disc displacement without reduction scenario. So deflection most of the time associated with disc displacement without reduction scenario, and deviation is most of the time is associated with subluxation, or it can be associated with displacement with reduction scenario also. Okay, so when it deviates to the right side and in full mouth scenario, full mouth opening, it again deviates to the normal position. That means disc now slips back to its normal position, where in initial situation it was in the anterior direction. We will discuss about this in the later section. So in deviation, in clinical from clinical examination, when we can find deviation, most of the time displacement with reduction and subluxation cases, and deflection we can find in the displacement without reduction scenarios. So joint noise, yes. So if we can find any kind of joint noise, then we should rule out either it is clicking, crepitus, or popping. Usually clicking is associated with disc displacement with reduction. Crepitus is a sound arising from the bone to bone friction. That is, condylar head now directly has touch or friction with glenoid fossa compound. There is no disc in between. Either disc anteriorly displaced or there is a perforation of the articular disc. So there results into the crepitus, that is bone to bone friction. Okay, so crepitus is a sound resulting from bone to bone friction. From one component of the bone is condylar head and another component of the bone is glenoid fossa or articular eminence. So we can find erosion in the condylar head, and also we can find erosion in the articular in the posterior slope of the articular disc or in the glenoid fossa component from CVCD. And again, popping sound mostly associated with TM joint subluxation. Okay, so there is the three kind of noise commonly you are find. Okay, so if any patient complains that there is a joint noise, we should want to know that what is the duration of the joint noise. Okay, most of the time patient complains like this: initially I have joint noise and later on it disappears. Now there is no joint noise, but I got limited mouth opening or not enjoying the full range of mouth opening. That is restricted mouth opening. So we from this kind of history, that is previously there is a joint noise and followed by no noise but reduction of the mouth opening. This kind of history suggests that patient is suffering from disc displacement without reduction. Initially, the joint noise from disc displacement with reduction. Now it is ultimately turns into disc displacement without reduction. That's why there is a limited mouth opening. Okay, and okay. So source of the pain can be myalgia or arthralgia. So if we are thinking that pain is from the myalgia, so we should try to rule out there is masticated myalgia or myofascial pain. For this, palpation is very much crucial, and so we can find trigger point also during palpation. So for excluding for that is evaluating from myalgia and arthralgia, we can go with Mahan's test. What is Mahan test? We can put two ice cream stick along the canine region and ask the patient to bite. If the patient suffering from pain, the ipsilateral side of the ice cream stick, it means patient is suffering from myalgia in the ipsilateral side. Okay, but if the patient if the patient can feel the pain of the opposite side of the ice cream stick in the joint, then we can think this patient is suffering from arthralgia. So same side of the ice cream stick, if the pain arise from the same side of the ice cream stick, this is myalgia. But if the pain results from the results is the pain initiate in the opposite side of the ice cream stick, then it is arthralgia. Okay, so we can use ice cream stick or we can use wooden spatula also. So because why this is the pain? Because biting on a rigid interface placed unilaterally in the molar region or premolar canine region, which causes frontal upward and rotation of the condylar head in the contralateral side, which results into the pain in the contralateral side in the arthralgic scenario and ipsilateral pain in the myalgia scenario. Okay, so we can differentiate with this kind of Mahan stress in between arthralgias and myalgias scenarios. And we can go with diagnostic block also, like if we want to exclude the odontogenic pain, then we can go with infralveolar nerve block if we can suspect that pain from mandible. And we can go with posterior supraalveolar nerve block, medial supraalveolar nerve block, or anterosupraalveolar nerve block if we suspecting that pain from odontogenic but from maxillary too. Okay, but we can go with also auriculotemporal nerve block if we can suspect that this pain is from the temporomandibular joint component, either from the disc or from the muscle associated with temporomandibular joint. Okay, so pathology ranging from MPDS, disc displacement with reduction, disc displacement without reduction, and subluxation. At first, muscle issues. So most of the time, muscle issues we can find tender muscle. Okay, either unilateral or bilateral. There should be focal area. Patient can really identify the point of the pain. Okay, so focal area, there should be focal area or trigger zone. There should be history of recent onset, and it most of the time it is associated with related with functional load, increased load, or it can be associated with stress, and it psychological component also associated with this kind of myalgic pain also. So myogenic pain is very much common, around 50% of the TMD scenario. So from DCTMD 2014, we can further classify this myofascial pain into three types: myalgia, myofascial pain, and myofascial pain with referral. So what is myalgia? Myalgia means local myalgia means if the pain is located within the trigger point or within the focal point. Okay, and what is myofascial pain? If the pain locates within the boundary of a particular muscle, boundary of a masseter, boundary of a temporalis, boundary of a diagnostic muscle, okay, or lateral trigger muscle. So within the boundary of the muscle, okay, a focal point, and it radiates within the boundary of the muscle. This is called myofascial pain. But if the pain radiates beyond the boundary of the muscle, okay, so this is then it is called myofascial pain with referral. So it is three types myalgia. So so pain of muscle origin, the pain reported on the palpation only in the area being palpated, okay, focal point, and myofascial pain spreading beyond the site of the palpation but within the borders of the muscle, in a particular muscle. And myofascial pain is referral with the pain spreading beyond the borders of the muscle that are being palpated. Okay, so these are the three types.
Sorry to interrupt. You have 10 more minutes, Doctor. Thank you.
Only 10 minutes.
For the lecture, we have 45 minutes and it's been going 10 more minutes.
Okay, I think I need at least 20 minutes, at least. Minimum. If you can consider.
Okay, but probably if we can make it concise, Doctor. Thank you.
Okay. So now jump to the main topics. So for disc issues, so we can find like this. So this is the typical sound from the joint clicking. This is the typical sound what we are find from joint clicking. Okay, and joint noise and joint clicking is most of the time associated with disc displacement with reduction. So see, so disc is displaced in the anterior direction, and initially it is displaced along the anterior direction and then again back to its normal position. So this is disc displacement with reduction, and this sound results from the disc is slide over the condyle, and which results in this kind of clicking sound, and sound depends on the amount of the friction, and most of the time this is a ipsilateral scenario. Okay, and from the MRI point of view, this is the closed mouth scenario. So disc is normally in the closed mouth scenario, disc is anteriorly displaced, So this is disc is anteriorly displaced, and the during open mouth, disc again comes back its normal position during the open mouth scenario, and this is called anterior disc displacement with reduction. Okay, so closed mouth and open mouth. And now from the cadaveric anatomy, you can find this. So this is disc is displaced back to its normal position, and in the resting mouth position, it again comes back to its anterior location. So this is displacement with reduction. Okay, and causes may be trauma, bad habit, TM joint arthritis, this kind of stuff. Now moving to the next. So there is no joint noise, and disc always locates along the anterior part of the condylar head. So this is disc displacement without reduction, and this without reduction ultimately results into limited mouth opening. So disc always enter to the condylar head, and disc cannot reduce back to its normal position, and thereby there will be a history of joint noise, but currently there is no noise, and pain in front of the ear, and jaw shifted or deflected to the affected side. Okay, so in case of disc displacement without scenario, we can find joint can be deflected to the affected side, either it is right side or left side. So, and from the MRI view also, so this is closed mouth, where we can find there is disc is already anteriorly displaced, and then the open mouth scenario, and also disc is anteriorly displaced. There is no pushback to its normal situation. So this is closed mouth and this is open mouth. This is always in the anterior part of the condylar head. So this is disc displacement without reduction. And again from the cadaveric anatomy, and so this is see, disc always lies to its anterior location from the condylar head. No pushback. So causes again muscle spasm from the lateral deviate muscle, bruxism or TM joint arthritis. Okay. So disc displacement can be present with intermittent lock or with limited mouth opening. Okay, or in the later stage without limited mouth opening. So this is disc displacement without reduction, because disc always locates along the anterior end of the condylar head. So we already discussed that around 30 to 40% population presents with sleep or displaced discs. So displaced discs without any kind of symptom is not a problem. Okay. Now coming to the ligament problem, that is, so this is called joint popping sound, and this is result due to condylar head now travels beyond the articular eminence. See, beyond the articular eminence. We can replay it. So this kind of scenario sound is different from what we can get in crepitus or clicking. See. Okay. So this is called popping sound, and this popping sound clinically this is presented as an open lock. Okay, and condylar haze is totally displaced beyond the articular eminence. Okay, and most of the time this is bilateral scenario, and diagnosis is TM joint subluxation. See, can you see the preauricular area? So ultimately, in clinically, we can find preauricular hollowness in this kind of situation. See, and this is deviation. I already mentioned previously that in case of subluxation, we can find deviation. So this is the deviation typical presented with TM joint subluxation along with preauricular hollowness, because condylar head now locates anterior part of the articular eminence. And from the TM joint tomography, we can clearly appreciate its location. That is, this is right TMJ in the closed mouth scenario, and the open mouth scenario, condylar head now totally travels anteriorly to the condylar head articular eminence in the right side, and the same thing in the left side. So this is TM joint subluxation, and it ultimately this Now, in the open mouth cases, there is no condylar head within the glenoid fossa. Thereby, we can find pre-auricular hollowness during palpation. Okay, so this can be result from joint hypermobility, arthritis, pencil-shaped condyle, or congenital deformation. So TM joint circulation. Okay, so this can be classified further type 1, type 2, and type 3, ranging from condylar head now locates just below the articular eminence, which is type 1. In between articular eminence and the zygomatic arch, this is type 2, and the beyond the zygomatic arch or the level of the zygomatic arch, this is type 3 of the TM joint subluxation. So for imaging modalities, we can go with CBCT or CT scan, and for soft tissue, we can go with MRI. But from American Academy of Orofacial Pain, they give us some recommendation about the imaging from the history. Like if the patient has the history of intermittent locking or limited range of movement, we can go strictly for MRI, TM joint MRI, because we are suspecting that patient is suffering from disc displacement without deduction, and that's why MRI is the main imaging modalities. Okay. But if from the clinical aspect, if we can find crepitus, grinding, or gritty sound during palpation, that is crepitus, then we can go with CBCT, because from CBCT we can clearly define the bony component, that is articular eminence and condylar head component also. But if the patient complain of sudden, unilateral, severe stabbing pain or shock-like pain, electric shock-like pain, then we can consider it is a neuralgic pain. Then we should go for MRI of the brain with FISTA protocol or trigeminal protocol to rule out any kind of compression from superior cerebral artery to trigeminal ganglion. Or we can go with OPG or orthopentanogram to rule out any kind of intraoral or dentoalveolar pain. Okay. So for serological component, if we can consider or if we can suspect this is the arthritis scenario, so we can go with rheumatoid factor, we can go with ANA, or we can go with NTCCP. If the patient is rheumatoid factor positive or ANA positive or NTCCP positive, so patient is suffering from rheumatoid arthritis. But if the ANA is negative, rheumatoid factor is negative, but in rheology we can find the degenerative changes, then the patient is suffering from osteoarthritis. And now from seropositive or seronegative, if the patient is suffering from HLB27 positive, then we can consider that this is a seronegative arthritis. So it can be ankylosing spondylitis or psoriatic arthritis. Okay. But if the patient is suffering from high CRP and high ESR and with the pain in the temporal component, then we can consider this is a giant cell arthritis. So from the test, we can ranging from orthopentanogram and MRI. Okay. We already mentioned the normal position of the disc. So normally the angle between the posterior border of the disc and midpoint of the condylar head should be 30 degree. If it is beyond the 30 degree, then it is antero-disc displacement. So we can consider up to 30 degrees is normal, more than 30 degrees is antero-disc displacement. If it is ranging from 31 to 50, this is moderate. 51 to 80 moderate, and more than 80 it is severe disc displacement. Okay, so this is a disc displacement scenario. Okay. So I just directly go through the some degenerative changes. Okay, so from degenerative changes we can find surface flattening. This kind of surface flattening, and surface flattening ultimately results into the increased joint space. Okay. And we can find subcortical sclerosis. This is a feature of subcortical sclerosis, which is a feature of joint remodeling. And we can find osteophyte beak-like projection along the antero border or antero slope of the condylar head. Okay, this again remodeling feature. And we can find surface erosion like this. Okay. And again we can find subcortical sclerosis. So these are the feature of degenerative joint disease. So from RDC TMD criteria or digital diagnostic criteria of the temporomandibular joint disorder, we can find grade 1 and grade 2. So in case of grade 2, if there is osteophyte, erosion and cirrhosis but less than 2 millimeter, this is grade 1. But if it is more than 2 millimeter and more than one feature like osteophyte with erosion, erosion with cirrhosis, then it is considered as a grade 2 degenerative joint disease. Okay, so this is a typical osteophyte, this is typical subcortical cirrhosis. Okay, subcortical cirrhosis and osteophyte, and there is no joint space. And again, this is a subcortical cirrhosis. This is a flattening of the temporomandibular joint, and this is also osteophyte of the condylar head. Okay, these are various kind of severe degenerative changes of the condylar head. So this again osteophyte, this is erosion, this is subcortical sclerosis, this is again erosion, this is increased joint space due to flattening of the condylar head. Okay, so these are typical CBCT report where we are using all this kind of data, either it is any kind of erosion, osteophyte, subcortical sclerosis, what is the type of movement of the condylar head, either it is any kind of hypotranslation or hypertranslation. Okay, we are trying to include all of this in our center for CBCT reporting. We can find bifid condylar head also. Okay, so another cause of the limited mouth opening can be trismus. Either it is due to infravalvular nerve block or any kind of surgical procedure like extraction or molar extraction. So now, how to manage this condition? This is very, very important. George Domitocrolis is direct my mentor, and from his recent literature, we can directly describe this. The management of the temporomandibular joint. So, category 1 is if the patient is complain of TM joint pain only and OPG reveals normal and MRI normal, then we can go with medication like this kind of normal MRI. Then we can go with medication and occlusal splint, like painkiller, muscle relaxant, this kind of stuff, and along with occlusal splint. Okay, so if OPG is normal and MRI is normal, but category 2 reveals that if the patient complain of intermittent joint pain with joint locking, or joint clicking with occasional joint locking, and MRI reveals that anterior disc displacement with reduction. Okay, and then our treatment should be TM joint arthrosynthesis, that is or arthroscopic lavage and lysis. If the patient complains of continuous chronic pain with closed lock, that means disc always situated anterior to the condylar head, and diagnosis is disc displacement without reduction, then we should consider arthroscopic procedure like arthroscopic arthroplasty or disc depletion or disc repositional surgery in case of category 3 type of disease. And in case of category 4 type of disease, where we can find both disc pathology and along with early condylar changes like osteophyte and condylar head flattening. And in that kind of scenario, we should go with TM joint discectomy or condyloplasty or shaving. Okay, in case of category 4 type of disease. And in case of category 5 type of disease, we should like this kind of severe changes of the condylar head, subcortical cirrhosis, osteophyte, this kind of stuff. Then we should consider TM joint dissection, that is total TM joint replacement surgery. So this is the summary of the 5 category temporomandibular joint disorder and their treatment. So, treatment protocol of the temporomandibular joint disorder ranging from muscle exercise and occlusal splint. So occlusal splint can be stabilization splint, can be anterior repositioning splint, or can be both. So when to use oral orthotic splint, that is at first if the patient complains of myofascial pain, then we should consider soft splint, that is 2 to 4 millimeter soft splint. Okay, only myofascial pain. But if the patient is suffering from TM joint disorder like disc displacement, arthralgia, arthritis, then we can consider stabilization splint following arthrosynthesis and arthroscopic procedure at first, and followed by stabilization splint, that is anterior repositioning splint. But if the patient is suffering from bruxism or parafunction, then we can consider hard spleen, 2 to 3 millimeter hard spleen. And if the patient is complain of post-surgical trauma, post-surgical pain, then we can consider soft spleen. So this is very much important when and what kind of orthotic spleen we should use. Okay. So from arthosynthesis, from my fellowship's protocol, we are using that is one peak arthosynthesis, and arthosynthesis should be performed within the 3 months of the initial onset of the symptoms, not more than that. Okay, in the early stages of the joint pain, because in the if we can go with arthosynthesis in the initial stage, that is initial 3 months, then success rate can be hit up to 95% in the blind technique. But in the arthroscopic, and success is much more higher, around 80 to 90%. So these are typical 2-point arthosynthesis. 2-point arthosynthesis. Here is the typical 2-point arthosynthesis. See. But as this is a blind technique, so finding 2-point accurately within the joint space is very much difficult. That's why we are came across with this kind of very important and very specific arthosynthesis, that is 1-peak arthosynthesis. This is my regular practice in my country for disc displacement with reduction and without reduction scenario. So we introduce at first bupivacaine under GA. At first patient is under GA, and we introduce bupivacaine to inflate the joint. And then another part of the needle we introduce dextro Linger's lactate. And with this we can precisely lavage and lysis, lavage the joint and lysis the fibrous adhesion. And followed by injection of the PRP, that is growth factor platelet rich plasma, within the joint capsule. And if the joint has any kind of erosive feature or degenerative feature, then we can also use hydrocortisone. So no scar mark. So this is typical. This is another case. Same kind of disc displacement without reduction with joint effusion. See, disc displacement without reduction with joint effusion. Similar kind of procedure. So this is very much predictable treatment for lavage and lysis in compared to 2-needle arthosynthesis. And he is the inventor, Professor Dr. Darpan Bagrova, my mentor. And this is the 1-peak needle, what we are using for this. Okay. So, and so this is the summary. When to do lavage and lysis. Only for category 2 type of TMJ and early category type of 3 type of TM joint diseases. Okay. So this is the most important thing, because in later scenario or late cases, there is no role of the arthosynthesis like this. In that cases, in the later cases or category 4 or category 4 type of disease or later category 3 type of disease, we should go open, like anterior disc displacement in the open mouth. So we should go with open surgery like this. Here is we can see there is a perforated articular disc, and we just reposition this articular disc in open in the open cases. Now, the last part, the TM joint subluxation. TM joint subluxation can be primary, can be secondary. So, for TM joint subluxation, the mode of treatment is flow therapy. So, in case of flow therapy, we are using dextrose. Okay, dextrose ranging from the 8% to 25% dextrose. So, here is the patient is under sedation, and we are introducing 25% dextrose directly in the joint space and the pericapsular area. Okay. And this is the another side. And this is the result. Sorry. This is the result. See, this is initial preoperative right TMJ close mouth and right TMJ open mouth. Condylar head moves beyond the articular eminence, both right side and left side. But after flow therapy, see, there is no TM joint subluxation. Now condylar head is behind the articular eminence, which is totally normal. So this is post-operative. Okay. And again, another case. And last stage, that is, if we can consider, we should go with arthroscopic procedure. Here is a video of arthroscopic procedure. Like this is. And this is from my mentor, Professor Dr. Gary Overton. He is currently a chair of University of Maryland, USA. Okay, so this Gary Overton, my mentor. So, and this is various kind of arthroscopic finding of the joint, that is from retrodiscitis, adhesions, okay, and various kind of synovitis. We can find large perforation also. So we can clearly visualize the uh, inner scenario of the joint with this arthroscopic feature. Okay, and the last option is the for the category 5 is total TM joint replacement, that is TJR. Thank you. This is all.
Okay, thank you, Dr. Biplob, for the intriguing lecture and amazing videos. I believe we should have more sessions to address all the TMD subject. Okay, but since our time is quite limited today, now let's jump into the Q&A session. We already have 3 participants asking you here. Okay, first is from Dr. Kira. Good afternoon, Dr. Biplob. My name is Kira. First of all, I would like to thank you for today's very interesting and insightful lecture on temporomandibular joint disorders. I found the discussions really engaging and highly relevant to clinical practice. From what I have read, TMD can sometimes present with symptoms that resemble dental or neuropathic pain, which makes the diagnosis quite challenging. That's why I would like to ask, how can we differentiate TMD pain from odontogenic pain or trigeminal neuralgia? Okay, I leave it to
Okay.
you.
Thank you, Dr. Tira. This is very good question. I think I already described in my lecture this question, this answer. So this is very much crucial to differentiate between odontogenic pain and trigeminal neuralgia. In case of trigeminal neuralgia, most of the time, patient complains of unilateral pain, severe shock-like pain, which is very short duration in time, like 3 to 5 seconds or 10 seconds, and after that it disappears completely, and there will be no deformity in the TM joint component. There is no deformity of the condylar head. There should be no disc displacement, and there should be no subluxation scenario. And that's why that's how we can differentiate between TM joint neuralgia and TMD. And the same time we can differentiate between odontogenic pain also. In case of odontogenic pain, most of the time odontogenic sinusitis can be associated, because in case of odontogenic sinusitis, pain can be refers to the ENT area, that is ear area. Okay, and in that case we can go with cvct of the maxilla. We should rule out the quality of the endodontic treatment or any kind of endodontic pathology that remains in the maxillary tooth. Okay, and then we can rule out it as a odontogenic sinusitis, that is called maxillary sinusitis of odontogenic origin, that is MISO. Okay, so if there is MISO, then you can find again pain to the TMJ, and this pain is from the odontogenic pain, which is refers to the TMJ area, not pure TM joint pain. Is this answer your question?
Is that answering your question, Dr. Kira?
Yes, thank you, Dr. Biplob.
Okay, welcome.
All right, let's moving on to our second question here. Good afternoon, doctor. My name is Asha. Thank you for your remarkable presentation. I have a question regarding TMD disorder. For patients with mild TMD discomfort, such as jaw fatigue without any history of jaw locking or dislocation, what kind of home-based management or self-care approaches would you recommend to help relieve patient symptoms and prevent further progression?
Okay, thank you, Tasha, for your question. But again, we should consider the proper diagnosis at first. So if patient has discomfort, we should find out the cause of the discomfort. Either it is a myogenic origin or it is arthralgia origin. Either is there any associated with symptomatic disc displacement or not, or is there any kind of joint clicking, joint noise, or joint popping. So we should focus, or we should stick to diagnose the case first, and after that we can consider the treatment. Okay, first we need concise diagnosis. So if the diagnosis is myofascial pain, then we can consider muscle relaxant, painkiller, and stabilization spleen. But if the diagnosis is degenerative joint disease with disc displacement with reduction. Then we should go with arthrosynthesis or arthroscopic joint lavage and lysis followed by stabilization split. Okay. Or if the diagnosis is disc displacement without reduction, then we should go with arthroscopic procedure and followed by anterior repositioning split. Okay. Or the diagnosis is TM joint subluxation, then we should go with prolotherapy. So it totally depends what kind of diagnosis is, and we should plan accordingly. Is this answer your question, Tasha?
Yes, thank you, doctor.
Okay, welcome.
Okay, maybe we can also refer to what Dr. Biplob has presented to us, the table. Yeah, doctor?
Yes. Okay.
I believe that would be very helpful for us. Okay, well, the last question. Good afternoon, doctor. My name is Tommy. Thank you very much for your insightful lecture, Dr. Biplob. It was very clear and informative. Okay, I would like to ask, especially your first lecture about oral mucosal disease or after treatment TMD. Many cases in my country, we encounter patients who do not fully comply with our instructions, particularly regarding oral hygiene, nutrition, and medication. Could you please share some strategies to improve patient adherence to treatment? Okay, thank you, doctor. Maybe
It's
share your
difficult.
experience.
Yes, it is difficult, Dr. Tanmoy. Tommy, sorry. So it is difficult in our scenarios also, but we can go like this way, we can give some bad information, like kind of information that triggers more fear about the disease, and same time we can reassure the patient. Okay. So if we can go like this, some kind of fear component and some kind of reassurance component, then patient will stick to our advice. Okay. But if we can just only reassure that we can manage your lichen products, we can manage your erythema multiforme, no worries about that, then patient will continue most of the time 2 or 3 months the treatment you are providing, and after that he will disappear from follow-up. Okay. So I think we can make a balance between fear component and reassurance component of our treatment.
Okay.
Is this helpful for you?
Yes, thank you, Mr. Doctor.
Okay.
Okay. Right. Distinguished participant, it seems that Dr. Biplob has addressed all the questions. I believe you have many questions on your mind, but I think you need to email him directly. If you can contact me, I will let him know about your question. But as we come to the end of today's session, I would like to express our heartfelt gratitude to Dr. Biplob for his insightful and valuable lecture, both about the oral mucosal disease and today about the TMD. And of course, thank you to all participants for your active engagement. We hope this guest lecture series has been enriching and beneficial for everyone. And I will not close the possibility for us probably to visit you and maybe learn more about you, maybe hands-on, probably on the next session, doctor, because it's really interesting. Yeah, all right.
Inshallah.
Okay.
Inshallah.
Inshallah. Okay, everyone, see you again in our next session and have a wonderful day ahead. Back to you, Ellen. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Sarwer Jamal Biplob, for an intriguing lecture, and thank you, Dr. Dewi Zakiawati, for moderating our event today. Let's cheer for both Dr. Sarwer Jamal Biplob and Dr. Dewi Zakiawati. On behalf of the Faculty of Dentistry, Universitas Pajajaran, we would like to present certificates of appreciation to our distinguished speaker and moderator as a gratitude for their valuable contribution to today's event. First, we would like to present the certificate to Dr. Sarwer Jamal Biplob, and our documentation team will assist us to take the picture. Let's capture the picture on my count. 1, 2, 3. Next, we would like to present the certificate to Dr. Dewi Zakiawati. Once again, our documentation team will assist us. 1, 2, 3. Everyone, this marks the end of our today's event. I sincerely hope that you have enjoyed and derived numerous benefits from this gathering. I extend my gratitude to the honorable professors, doctors, and participants for gracing today's meeting. If there were any areas where we fell short during this session, kindly provide us with your valuable feedback for our future enhancement. Wishing all a pleasant afternoon, good health, and a wonderful day ahead. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Okay, thank you so much. Assalamualaikum.